Hi, everyone. Welcome to today's session, which is focused on advancing and using health equity frameworks as a tool. My name is Nandini Saxena. I'm a knowledge translation specialist with the National Collaborating Centre for Determinants of Health, and I'll be your host for today's session. So just a few housekeeping items before we get started. Our conversation today is going to be recorded and it'll be shared with registrants via email and posted on the NCCDH website. I invite you to use the chat box that you'll see at the bottom of your screen for conversation with everyone. And if you're comfortable, I invite you to introduce yourself and share where you're from. Jonathan Heller with NCCDH is going to be our chat box moderator for today's session. And we'll be adding resources to the chat box as we go along, and feel free to share any resources that you'd like to share as well. And if you have questions or comments for the speakers, please use the Q&A box, which is also at the bottom of your screen. And thanks to Carolyn, who is providing tech support for this webinar, also with NCCDH. So before we get started, I'd like to share a land acknowledgement. And what you see up on the slide is NCCDH's land acknowledgement. And the key elements of this acknowledgement are that the 1725 treaties of peace and friendship between Mi'kmaq and Wolastoqiyik peoples and the British Crown do not deal with the surrender of lands and resources, but instead recognize Mi'kmaq and Wolastoqiyik title and created rules for what was intended to be an ongoing relationship between nations. For myself, I'm joining from Treaty 13 territory, which is the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and it continues to be home to many Indigenous peoples from across Turtle Island. Treaty 13 was established in 1805 at a time when Black people, forcibly brought to Turtle Island through the transatlantic slave trade, were enslaved or actively resisting enslavement. And when the enslavement of Black people was a common practice among members of the early Upper Canada legislative assemblies, now Ontario, and this is documented between 1792 to 1800. So NCCDH is one of 6 national collaborating centres. We're funded by the Public Health Agency of Canada, and we were created post-SARS. Each centre has a particular focus, and our focus is supporting public health to take action on the structural and social determinants of health to advance health equity. And as referenced, we're located in Mi'kmaq, now known as Nova Scotia, and we're hosted by St. FX University. I'd like to welcome our speakers. We have 4 amazing speakers who are going to be joining us today. So Karen Roundpoint is a social determinants of health nurse with the Eastern Ontario Health Unit, joined by her colleague Chantal Lalonde, who works as a program manager. Then we have Eric Hemphill, who is the acting executive director for the Nova Scotia Department of Health and Wellness, and Dru Armstrong, who works as an evaluation and impact manager with Health and Wellbeing Queensland, Australia. And we were chatting just before today's call started, and she shared that it's actually 2:30 in the morning for her. So I'm so grateful, Dru, and grateful to all of you that you are joining us as speakers and for agreeing to really share your work in this space. So in terms of what we're going to do today, the way that we're going to structure today's session is really share with you some key findings from a review of the literature on health equity frameworks, and also to share some of the key themes that emerged at a recent online convening also on health equity frameworks. Then we're going to hear from Dru, Chantal, Eric, and Karen, their stories of how they've been using health equity frameworks in their own different contexts. And then we'll make sure that we reserve a good amount of time to hear from you in terms of any questions that you might have for our panelists. But before we get started, I'd invite you to take part in some polling. We'd like to hear from you. So the way to join the Slido poll is you can either take your phone and scan the QR code, or you can go to slido.com and then enter in the participant number that you see up on the screen. So recognizing that many of you on the line are deeply involved in doing health equity work in your own contexts, we wanted to hear from you to help us sort of frame some of this conversation. So the first question that you see up on the screen is, are you using a health equity framework or health equity strategy to guide your health equity work, and why or why not? So I'll just wait for a few moments as people type into the Slido. And I see there's about 31 people typing. So there's quite a few of you who are starting to engage. And yeah, there's a few yeses. And one person has said it's because we don't know what to do. And then there was another comment which said, no, we don't have support from leadership. And then another one, which we'll be speaking to later, is that people are saying yes, because the organizational plan in your particular context is including health equity as part of the strategic plan, which is definitely a way of of moving forward health equity. Another person saying not right now because I'm not familiar with them. Hopefully through today's webinar, you'll become more familiar. And someone is saying just starting, we're in process. And again, speaking to one of the potential benefits is that it can be used to help guide our work. So thanks so much for taking part in that first Slido poll question. I'll move us on to the next Slido poll question. Even though I see there's people really typing and loving this question, which I really appreciate. Yeah, yes and no, guided in part by the Ontario Public Health Standards. Fantastic. So I'll move us on to our next question. Thank you so much for taking part in that first question. So what is a challenge you experience with implementing health equity work? And again, the reason why we're asking some of these questions is that we really want to, through some of the panelist stories, share some of those challenges and some of the enablers to health equity work. So people are typing in terms of challenges. So one challenge is leadership and organizational buy-in, lack of capacity, the need for resourcing and implementation supports, the question of who takes ownership of this work. And also, yeah, absolutely, it's relational. And so how do you build that relationality into a health equity framework? Some managers don't get health equity, and there are no supports in place. And this is a piece of work that we're doing off of the side of our work, even though we know, all of us know on the line, that health equity work is something that you need to center throughout an organization's work. The political context, absolutely. Thank you for naming that. Yeah, this is amazing information and content, challenges with capacity, lack of data on populations who experience different forms of equity, leadership that is not bold enough, and a system that is not designed for this. So these are fantastic insights, and really appreciate you all taking part in this poll. I'll just wait a couple more seconds and then I'll move us on to our next poll, which is the contrasting question, which is, what is an enabler that you experience with implementing health equity work in your context? Yeah, absolutely. Good partnerships, good relationships, having management and leadership that is bold and progressive. The need, again, leadership support and buy-in, connecting with community organizations, the need to center the voices of people with lived experience of different forms of oppression. An enabler is that it's a part of your strategic plan, having champions in place, passion and commitment, partnership with all different sort of communities, having management buy-in and support, leadership and education, having data that you can use to drive some of this work, making it a priority. And I think one of the other mechanisms that people have talked about is having it clearly articulated in different organizational document. Senior leadership support and understanding, having direct leaders that are advocates. I think everything that people are sharing is going to come up in different ways across the stories that we're about to hear. So I'll just give it a couple more seconds and then I'll move us on to our next section of the webinar, which is where I'll be sharing some of the highlights of findings from the review of the health equity frameworks literature and also a recent online convening that we did. Commitment from the organization, education on the subject. Yeah, all fantastic insights and really appreciate you sharing those. So I'll move us on now to this review and online convening and share some of the key results from that process. So why did we do a review of health equity frameworks? One of the things that has come up multiple times is around what some of the benefits and the pitfalls of these frameworks are. So an example of a benefit is that they offer flexible guidance on ways to move forward together in a coordinated way, helping to achieve greater impact. A pitfall that I've heard, and this was from the convening, was that it can be used to facilitate performative action only. And can the language in a health equity framework convey the full scope and depth of the work that's required? We conducted this review in partnership with the BC Ministry of Health. And some of you might have attended a webinar we hosted just a couple of weeks ago where they shared their new population and public health framework, which has a really strong grounding in health equity and anti-racism work. So what you see up on the slide is the research question that we used to guide this literature review. And we were really focused on identifying actionable health equity frameworks. So frameworks that can be used to advance action. So through the review, we identified a total of 47 frameworks. 18 of those 47 were focused on advancing equity for Indigenous or Aboriginal populations in different geographies, including First Nations living at home and away from home, Inuit, Métis, Maori, and Aboriginal and Torres Strait Islander people. The frameworks are from primarily from the US, then from Canada, Australia, Europe, and New Zealand. What we also found is that the frameworks are grounded in a range of different theories, including critical race theory, system theory, and also are connected to different kinds of legislation or policy directives. For example, the United Nations Declaration on the Rights of Indigenous Peoples. Many frameworks also talk about how disrupting racism and rebalancing power are foundational to health equity work. And a framework about planetary health states, our claim that equity cannot be achieved unless and until structural and systemic racism are eliminated, means that elimination of racism is perhaps the most crucial aspect of the entire conceptual framework. We also found that there's a lot of variety in the framework type, level, structure, organization, and presentation, suggesting there isn't one single straightforward strategy to advance health equity. Just as to give you a sense as to some of the framework visuals, this slide just illustrates the range in how different frameworks are structured and visualized. And the visuals also indicate that some of the frameworks appear to emerge from different knowledge systems. So for example, in the top right-hand corner of the slide, you'll see a framework that was co-developed with the First Nations Health Authority focused on improving Indigenous cancer care journeys in British Columbia. And the areas for action are pictured as stepping stones in a river, supported by the sands of living well with trees on the horizon. And then you contrast that with the framework at the bottom in the middle, which is Ontario Health's Equity, Inclusion, Diversity, and Anti-Racism framework. And that framework is depicted as 11 jigsaw puzzle pieces, and each piece identifies a specific area of action. As I mentioned, back in 2024, we convened an online session with about 50 people. We co-developed the session with an advisory group. And the goal of the session was to support a culture of equity in health systems by fostering relationships and information sharing across people interested or using health equity frameworks, and also to co-create and accelerate learning about frameworks as a tool to disrupt systems of oppression and advance health equity for all. Our rationale in convening that session was really to collectively build on and share participants' practice-based knowledge, expertise, and experience, and also to address some of the gaps that we identified when we were doing that health equity frameworks literature. We will be releasing that frameworks convening report shortly, so please stay tuned for that. I think it was really exciting to learn from all of those participants who took part in that session. So thank you so much to people who were involved in that series. So in terms of the areas of focus that we looked at through the review and also the online convening, we were really looking at the development of frameworks, the implementation and use of frameworks, and what other supports are required, and then also the evaluation. So I'll just briefly go through the next 3 slides where I'll share some of the different areas that we identified. So in terms of development, co-creation, and adaptation, the review, a lot of the frameworks built on existing literature. So for example, other frameworks that they then adapted or research papers. Most of them were co-developed with partners. And as we know, this is an opportunity then to ensure that people who will be impacted by framework actions help shape what the work actually looks like. And this is illustrated by the quote on the slide, which is from the Western Australia Department of Health. So the framework recognizes that Aboriginal engagement and involvement is essential to improve Aboriginal health and well-being. What we found in the convening was that there was a lot of congruence with what was happening already in the literature, but I would say that it went a bit further in that people in the convening were saying that we need to ensure that frameworks center the voices and the needs of equity-denied communities. And underlying this was participants' reflection on the significance of sharing power and sustaining reciprocal relationships. The other theme that came up during the convening was, especially when looking to adapt a framework, there's a need to identify and interrogate the underlying assumptions and worldviews of that particular framework, and to ask, does it align with personal and organizational values, recognizing that frameworks can unintentionally transmit inequitable worldviews and systems in which they're created. Moving on to use or implementation and the types of supports needed, what we found is that most of the frameworks we looked at in the review, they talked about work that needs to be done, but they didn't offer a lot of information about how to implement. Mostly they provide only high-level recommendation. A theme that did emerge in the review is the need for co-implementation of frameworks with partners and with communities made to experience different forms of oppression. During the convening, there was a lot of discussion about what is needed to support implementation and use of frameworks. So some of the themes that really rose to the top were the need for leadership that is supportive and responsive, and is very importantly accountable, not only within the organization and to funders, but also to partners and to communities who have been denied equity. The other thing that also came up was the need for policies, procedures, legislation that is enabling, that really creates the space for this type of work to happen. Importantly, people also talked about the need to engage communities denied equity at all stages of this work. Another key theme that came up was around organizational culture and really the need for organizations to foster and sustain psychological safety and to sustain environments where there is space for people to learn through discomfort, and that organizations are transparent and create space for creativity for this kind of work to happen. And then finally, another theme that also emerged around use was sort of a requirement to have a deep understanding of the systems of oppression and a critical analysis of how to disrupt those systems. Moving on to my last slide for this section is around evaluation. So this is another area where we found there were actually quite a few gaps in the literature. There was limited information with actual evaluation results of health equity work. And so there was a sense, based when we were reviewing those 47 frameworks, that there was not a lot of evidence about what health equity interventions work. And there was also limited information about how to evaluate, so the methods and the measurement mechanisms to evaluate. But one of the themes that did come up was that a reason to evaluate is for accountability purposes. Just as I was mentioning in the previous slide, that you need to be accountable for this work. And evaluation is one way of demonstrating accountability. And given there was such a limited sort of findings in the literature related to evaluation, we kind of included a call in the literature review, which was essentially inviting people to evaluate the work that they're doing around health equity and the use of frameworks, and to share those results widely so that others can really learn about what works and what doesn't. And then very briefly, during the convening with the 50 people who we met up with back in 2024, they came up with a number of critical questions that need to be asked during evaluations of health equity work. So some of the questions that they identified were, who gets to decide what is success? Which really leads to the question, who was involved in creating, implementing, and evaluating the framework and the health equity work? Another sort of set of questions was around who is the framework for and who is it serving, which leads to the question, what changes for equity denied communities because of this work? And then a last element was around the need to evaluate the depth and the quality of relationships at all stages. So on that note, I will pass it over to Dru Armstrong. And she's going to share the first story in our panelist series of stories of co-creation and use of frameworks. So welcome, Dru, and so excited to hear your insights and your expertise. I'll hand it over to you now. Thanks.
Well, thank you very much for having me. I'm really excited to be here sharing the successes and constraints of co-creating something meaningful, but yet pragmatic, and importantly, building that co-owned momentum that was needed for driving equity actions. So firstly, I'd like to pay my respects to the traditional owners and elders past and present, for they are the holders of the memories, traditions, the culture and aspirations of Aboriginal and Torres Strait Islander peoples. I'm on the lands of the Yugara and Turrbal peoples of Meanjin in Brisbane. It is in the northeastern state of Queensland, which is one of 7 states and territories in Australia. Just a little context, our state has a population of almost 5.5 million in an area about 1.5 times as larger than Ontario. Mostly concentrated in the southeastern corner and along the coast, but also with many remote communities. Here we also have a 3-tiered government system, so with federal or national, state, similar to provinces, but potentially with less autonomy in sectors such as healthcare and education than yours, and local councils like your municipalities. So Health Wellbeing Queensland, we're a statutory body for prevention at the state level, and we have a legislated remit, and that's twofold: to reduce the burden of chronic disease and to reduce health inequity. So no mean feat there. We were established 5 years ago, and we have a CEO and a board with accountability to government. So onto the methodology slide. To progress that remit, we wanted to do something around health equity. Everybody was talking about addressing equity across many different portfolios, but it was the how that was much more difficult. So most attempts, although all are needed, sat mainly at the programmatic or service-focused responses, and efforts were often really siloed. To some of us sitting very much at the social determinants and systemy end of the prevention continuum, addressing equity is a lot more about removing the systemic barriers so that people don't need those extra supports in the first place. And to enable that, we wanted to lift our approach beyond just health inequity and also beyond specific priority populations. And so we took a systems approach. And our first step was starting with the evidence to investigate drivers to see if we could show that those same underlying drivers that interacted with health inequities also impacted on the inequities experienced in other areas, such as disparities in justice, housing, child development, or domestic and family violence outcomes. So we conducted a number of evidence reviews, 8 of them, on the drivers of inequity in those areas. By focusing on those common drivers of inequity, it really helped us with our buy-in. It was really quite a mobilising concept. We were able to engage a really diverse range of system leaders across government who could see themselves in the picture and recognise how our work, even though we were technically health related to the inequitable outcomes that they were also trying to shift. I also just wanted to mention another unexpected win with that focus on drivers. Rather than, I guess, taking a specific type of inequitable outcome like health, it really helped us to identify the problem without using disparity statistics. So stats, those stats that compare subpopulation groups, which can really perpetuate inequity. So it helped us avoid that. It also meant conversations could automatically go deeper towards those system level solutions rather than those short-term surface level fixes. And also it really helped us account for intersectionality a lot better. Our next step in co-creation was to gather evidence again, but this time from real people. We conducted interviews across a broad spectrum, from high-level decision makers to clinicians to lived experience practitioners. And then we qualitatively analysed those responses and used them iteratively in the framework development. We asked them about their understanding of inequity and its drivers, and also what was or could be done about it. We fed all that back into the framework, ensuring it reflected real-world insights rather than being just a purely conceptual model. We also reviewed current practices. As was being said before, there's often a bit of an absence of effectiveness of evidence that works. And so some of it also just doesn't make it to kind of the research literature. So we looked both locally and internationally at just practice to understand what was being done or what is espoused to be done in practice to address inequity. So that was things like equity champions or diversity inclusion legislation or community-led investment and governance models. So together, those interviews and reviews shaped both the why and the how of the framework. And I think this kind of evidence-based, really rigorous process really did give it some credibility, and the intent that it was to move beyond principles to actual mechanisms of change created a lot of interest and excitement. But one of the challenges at this point, even after all that work over about 18 months and many, many stakeholder conversations, still no one, even the team, really didn't know what the final product would look like. So it wasn't really like typical frameworks or strategies out there. It wasn't a typical government strategy. It wasn't a list of action commitments. Instead, it was really a framing tool, a way to think differently and to act differently and apply an equity lens to wherever you are working from. And it had to be usable at multiple levels. So whether you're an individual practitioner, a decision maker, a whole organization, or at the whole of government level. So balancing all those purposes was really complex. At the same time as developing the framework, we also were creating momentum for uptake. So really concentrating on building those relationships and shaping thinking as part of the process itself. So even in hindsight, I wouldn't think we would have done it any differently, because the process really helped us establish the necessary authorizing environment. And many of the people involved have shifted. Every single person we talked to, I think, had shifted just that little bit in their thinking or their intent to act or their knowledge on how to act. And that meant to me and to us that even without full implementation, that baseline for addressing equity continues to move forward. A really strong element in the development process is also the partnership governance approach, which I'll hopefully talk about as well. So onto the framework itself, essentially all this process led to 3 essential components: the root causes of inequity, acting at multiple change levels, and pragmatic ways to do things differently. And you'll see each 3 components where it says the 3 parts have their own part of the framework. So understanding differently, intervening differently, and working differently. So I'll just really quickly touch on them. This firstly is understanding differently. So understanding our equity system. It shows all the context within which equity can play out, those larger contextual things around the outer blue and green ring, and the aspects like disenfranchisement, dehumanization, disadvantage. All those things are working together to keep people left out, doing without, and hindered, mixed in on the right-hand side with the individual and household characteristics of people. That model is designed to work both ways, so that what happens in one area can feed back and influence one side and back and forth. So that really helped us to frame understanding the issue differently. Part 2 of the framework shows how each action, how we can take action in multiple ways. So no matter what we're doing or which of those people I listed before we are, we can actually do things in these 3 areas. So welcoming diverse views and widening our perspectives, either at an individual or an organizational or beyond level, maximizing strengths and connections, which is really about putting people at the center, empathy, trust, connecting services, wrapping and stacking around people, and then really looking at rebalancing and redefining the structures. So what is our decision-making processes or our funding models, or how are all those things actually impacting on equity? And part 3 of the framework tried to get down to a bit more of that pragmatic level. Under these, there's more suggestions, but a lot of work needs to be taken to actually enable change conditions in the first place. It's about growing positive social impact and an actual want to make a difference, rather than perhaps being driven by profit or commercialism. Acting together thoughtfully, a lot about being conscious of the biases that we have and working with that, and actually doing things differently. So not overly rocket science, but nice to put it in some distinct places. Where we're at now, but it's up on our Health and Wellbeing Queensland website. We spent a time putting together a kind of public user explainer video of the main components of the framework, and also from a government perspective, an equity guide for policymakers, which is essentially a checklist applied to a typical policy cycle. Where opportunities arise, the framework and that guide are being used to support equity-focused decision-making, definitely internally, and we certainly direct lots of people towards that. We've recently had a government change in our election, so it's probably sitting a little bit still at the moment, being the priority of waiting to find out what the priorities of the new government are. But basically, we've really tried to lay those foundations so it's ready to embed into practice. And just having it out there allows for that organic uptake where leadership and alignment exist, and we can draw on it when we need. So in summary, I think the legislative remit, the authorising environment, the relationship building, the focusing in on action, and actually really learning from the community were the things that kind of got it over the line. The thing I'm most probably happy about was our partnership governance approach. So we had a departmental governance group of government people, and then we also had a community governance group. So we really looked at trying to keep that power balance going so that the input that each group put in was treated as evenly. In fact, hopefully at the end, we possibly already went the other way. We stopped kind of asking the department people after a while and just focused more on workshopping kind of every word, every concept of the framework with our community panel. One of the major benefits, I think, of that was that it gave it that credibility again, and it helped us from a typical government approval processes and language edits be able to keep some of that kind of true language in there. So things like dehumanization, that probably never would have made it across the line if I hadn't been able to say, nope, our community members said that and there's nothing we want to change about that. So thank you. I can't wait to hear all your comments and questions later, and I'll now hand over to Eric.
Thank you so much, Dru. I suspected that it would be tough to follow you just because of the amazing work that you and your team have done, and now that has been confirmed. So thank you for that. So really happy to be here with you today. Thanks to NCCDH and Anthony for inviting me here to speak to our health equity framework that we have developed and are implementing here in what's colonially known as Nova Scotia, in the territory of Mi'kma'ki. Particularly, I'm speaking to you from Jabuktuk, which is colonially known as Halifax. And so I just wanted to give, again, a brief overview of our framework itself, where it came from, and what we're focusing on, what we're doing now. Overall speaking, we have a real focus here on the main health system service delivery partners within the province. And so we're talking about not just the Department of Health and Wellness, which is the organization that I'm a part of. And quick clarification, I'm not just the executive director of the Department of Health and Wellness, I'm the executive director of the equity and engagement team here within the department. And so we have 6 total health system service delivery partners who are sort of falling underneath the umbrella of our health equity framework. First being Department of Health and Wellness, and we are, I would say, the owners and sort of ultimately accountable for the delivery of everything underneath the health equity framework. But we also are working with other partners within government. So the Seniors and Long-Term Care Department, which is, of course, a separate department with its own minister and leadership structure. We have 2 offices, one focused on addictions and mental health, and the other on healthcare professionals recruitment. And then when it comes to actual service delivery on the ground in the health authority level, it is Nova Scotia Health, which serves the whole province for pretty much all types of care, and then IWK Health, which is primarily focused on serving women and children and families. So with those 6 partners, they all fall under the sort of general auspices of the health equity framework in terms of not only being party to the development of, but the delivery underneath as well. So that's just a bit of provincial context in terms of the organization. Generally speaking, in Nova Scotia, I think like most places, certainly in Canada, we're experiencing a rapid pace of growth, and I would say mostly from folks immigrating and moving to our province. And so that, of course, brings a wealth of diversity and also a need for our system to adapt to the diversity that's being presented with. In a province where, frankly, we're not really used to that level of growth, if I'm being completely honest. We're sort of, stuck out on the East Coast, far away from the center of the country, but certainly we're experiencing that now. And so all that's to really sort of underscore the importance of, not surprisingly, not just moving forward with the health equity framework and the implementation of it, but certainly the needs that the way our population is moving, and the needs that come with that are really being reflected day to day. So to get to a little bit more of the organizational context specific to where the framework here came from. The first piece, and likely I'd say the most foundational piece, is that it was named specifically in the Dismantling Racism and Hate Act, which was passed in the spring sitting of 2022. And that's, of course, the right-hand part of the slide. This came out from some engagements that were done in the development of this framework, or sorry, the development of the Act, I should say. To the point where enough information was collected about specific health equity needs with respect to the health system that it was added in as a specific deliverable. So this is a framework, and I'll speak to this a little more later on, hopefully, grounded in legislation. So it is something that we are mandated to deliver, something we're mandated to report on a regular basis, and of course, subject to all the pieces that would fall to any kind of government auspice, including, say, for example, the Auditor General or those sorts of mechanisms. So that's where it originally came from. Again, basically coming from that information that was shared during the development of the Act itself. The second is that it's also found under our current government's health plan, essentially, and it's called Action for Health. And then under Action for Health, there's 6 solutions. Solution 6 is where the health equity framework is actually named. And so not only do we have a legislative imperative to deliver on this, to develop first, of course, now deliver and implement, but we also are found and named as a priority in terms of what government has identified in terms of their own mandate in delivering on health service system improvement. So Action for Health is really just a system change guide in terms of what this government is looking for with respect to our health system in general. So that's kind of how it's situated. It's a little bit of a unique situation because again, I guess a slight clarification, the work that we're representing here sits at the government level and not at the health authority level. So that's a little bit of a different thing, but it is important because we are sort of sitting at as I mentioned, through the Act, we're sitting at a place where we have some legislative and government oversight on this, where the accountability flows down to our partners, and including us to deliver on that within our respective organizations. Next slide, if you wouldn't mind, Anthony. So what is the framework itself? So the actual health equity framework is essentially a guide for all of the partners that I mentioned before, including Department of Health and Wellness at the government level, to addressing and well, essentially the outcomes, the disparities in health outcomes with respect to the communities that use our health system and of course live in our province. One clarification I would say for this is, of course, I think everybody on this call is familiar with the social and structural determinants of health, and the influence, of course, that equity has on all of those. What we're talking about here and the scope of this work is constrained to within the health system itself, whereas broadly speaking, health equity, of course, includes many of those social and structural determinants and factors. Those factors are certainly in play as they always are everywhere. But within the sort of boundaries of our health system, how do those show up? What does it mean to folks accessing, or in some cases not accessing services? Why is that? And how do those social and structural determinants influence that? But I just wanted to be clear about the boundaries of this, because health equity, of course, writ large includes the many areas within the mandate of other departments across government, such as our Opportunities and Social Development Department, Communities, Culture, Tourism, and Heritage, Education, Justice, all of those. But here we're talking about, again, what the responsibility of the Department of Health and Wellness is, which is, of course, the health system. So that's the sort of broad boundary of this. So specifically what it does is give structure and direction around how we move health equity work forward. How do we resource things? How do we determine priority? And how do we deliver on those pieces within the framework to make our system better, safer, more appropriate, and more effective for folks? I mentioned the piece about health equity inequities. The outcomes piece is really clear. Of course, we wanted to make sure that we were tracking and making sure that we were having the impact we hope to achieve. I would say the interest of transparency, we still have some work to do on this. It'll likely come up again, and I think it's come up actually in the polls that Nandini shared and you all contributed to earlier. The lack of really good data, especially at a system level on many aspects of health equity. Certainly true here, and certainly something that we're focusing on going forward. So again, work to do in this area, but that's kind of where we are now. Next slide, please, Nandini. The framework itself contains 35 actions, and for clarity, we're talking about actions, not recommendations. These are things that need to be done. And we know they need to be done because of the way the framework was developed. And that it was through about 9 or 10 months of extensive engagement with community, with the public, generally speaking, through lots of in-person and online conversations, meeting with community leaders, community organizations, and again, capturing public perspectives on this, and more anonymously through a variety of different opportunities, both online polling and surveying, as well as in-person opportunities, say, for example, in public libraries across the province, where folks were invited to contribute their say and their experiences. We had lots of great response to that and collected a lot of very challenging, admittedly, information, maybe not surprisingly, in terms of what folks were sharing with us. But that information was used as the basis for every single, not just the 3 themes that are here, but every single action that's contained in this framework. So I would say, tongue in cheek, that for once, the information or the direction that's given here actually comes from the voices of folks who contributed in good faith to that process. There was nothing in here that government made up to fulfill or tick a box or anything like that. It's all coming from what was shared with us, which is obviously crucially important with respect to just doing engagement well, first of all, but also setting a direction that we hope will be meaningful and impactful for folks as we move it forward. So through the analysis of all that information, we were able to land on 3 large themes, and there is some crossover in between these, certainly. I don't think anything is really sort of clean in the health equity space. But those themes are around patient experience from the perspective, obviously, of folks using our system, the health human resources of our system. So what does it look like internally in terms of HR, and then how we as a system practice and what does that mean in terms of influencing health equity. So with respect to patient experience, again, high level, the general theme here is that so many folks who responded to our and contributed through conversations, they just don't feel safe within our system. There's so many places in different ways that folks don't feel safe, and that showed up in a number of the actions that are specifically either targeted with respect to what specific communities, for example, were sharing with us, or generally speaking, how our system functions. Safety is far and away the biggest and most common and strongest theme across what was contributed. So as I mentioned, I won't get into details in the interest of time, but certainly a lot of the actions specifically speak to some of those pieces around safety in that area, and also specifically what we need to do to address that. With respect to looking internally for health human resources, really key themes here around representation. We don't have a health system at any level, frankly, that really truly represents the communities that it serves. And so, of course, there's a number of ways that we've identified to address that, as well as how, like the skills and capacity that folks have within our system, again, at all levels, to deliver, culturally competent, humble, safe care that's focused on the patient and their family, and all those principles that underlie this work. We have a long ways to go in that. And so we need to be strategic about how we build that capacity, along with some of the more specific actions that are found elsewhere. And to that, with respect to how our system actually functions, we know that a lot of the ways that our system is based, how decisions get made, what information gets used to make those decisions, is really not very centered with respect to health equity or equity, as say, in general. So we understand that we don't do engagement very well, generally speaking, as a government or as a health system. if we do it at all, it's generally not done well. That's generally not done respectfully of folks' time and again, good faith. And so we're looking to improve that, not only from a perspective of how we do engagement, when we engage, for what purpose, but of course, how that information that's shared with us is used, and really being intentional about reflecting that back. So there's a really clear focus on engagement and how that informs the decision making in our health system, generally speaking. And then I mentioned the piece around data. Data is a real challenge. Our systems were not built to have data points or pipelines with respect to health equity. And so you're faced with a proposition of either creating a new pathway or data points to consider with respect to health equity, or attempting to retrofit a legacy system to collect that information, both of which are incredibly difficult to do. So again, that continues to be an ongoing challenge, but we're starting to try to address that through some of our work, which I'll explain on the next slide. Thanks, Nandini. So following the release of the framework in July of 2023, we spent most of the fall and early winter coming together as system partners, those 6 partners I mentioned earlier, to first of all get a sense of what was happening within our system. So doing a bit of an inventory of things that fell within various places of the framework itself, but also prioritizing where we wanted to start, because what we've put together here and what was shared by community to us is vast and deep. And so we know we can't do everything all at once. And so we had to put some very intentional thought around where we wanted to or need to start. And so here are the 6 places where we landed for priority initiatives that were started in 2024-25. Of course, most of these, in fact, actually all of them, I'm going to be honest, will have legs for years likely to come, because in and of themselves, they are complex initiatives, but these are things that we've started in the previous year, I guess this current fiscal year. So the first 3 are system level change initiatives. So we're talking about usually all 6 partners being engaged. In some places, some not as much, because it doesn't necessarily fall within their area. But generally speaking, the first 3 are initiatives where all 6 partners have come together to commonly work on an approach to address the particular focus of the issue. 1 and 2 being sort of 2 sides of the same coin, improving the systems that are in place for patients and their families to report instances of racism and discrimination that they experience within the system. We currently have a fair amount of work to do with respect to the safety and effectiveness of that system. And also, don't have necessarily the mechanisms through this to actually get an understanding of how often that would happen, despite the fact that it is vastly underreported based on the actual experiences. In part, of course, because that system isn't safe or effective, and that's just what's known in community. Second, and flipping it to more of the sort of internal focus, is the fact that folks who work within our system who identify as part of underserved or underrepresented communities don't feel like they have a safe and effective mechanism to report internal racism, discrimination that they experience. And so, not surprisingly, folks are living with all manner of mental health concerns, stress, lack of engagement, performance within their positions, high turnover, all the things that you would expect from living in that environment. And so there's a lot of development work happening there with respect to improving our health human resources system to be more effectively identifying and resolving those issues in a safe way. And finally, focus primarily on the data side of things. We talk, as I mentioned, about representation within our system. We don't actually have a great idea of who's working within our system and how those folks might identify to begin with. And so this workforce composition work is intending to start to address, give us a little bit better information, more consistent and clear information, clearly defined, I should say, around who's working within our systems now. Because right now, if we were going to be taking some action with respect to improving representation within our system, say through targeted recruitment or intentional, HR policies or strategies, we're kind of flying blind a little bit without that information being consistent. So that's the third focus, and that again applies across our system. Very quickly, when it comes to the fourth, fifth, and sixth piece, Health Equity Collaborative very quickly is the vision for it is a three-way partnership between health system folks who are working on health equity initiatives, the academic sector here in Nova Scotia, for which we are blessed with many academics who are focused on health equity work, including, of course, St. Francis Xavier University, where the NCCDH is located, as well as the community sector as well. So a three-way partnership between those organizations and individuals to be able to better inform the work that's happening within our system. This is really coming from a place of recognizing that we don't have all the tools, the data, the due diligence, and the evidence we need to do this work well. And so we're turning to our partners, both in the academic sector as well as community, to help us build this work with that information in hand. The fifth project is around a health equity charter. So considering the health equity framework is, where are the fires within our system? Where are those places where we need to focus? The health equity charter is more of a how-to. So there's a really, what we're hoping to develop is, and we've drafted this, but it's not public yet because we're still engaging with folks about it, to be able to clearly define what are the principles that underlie all of our work, or how an organization should work in doing health equity work well. And what does that mean in terms of actions? What are some key things that organizations can do to actually live into that in a real way? So that's what the charter is meant to be. And ideally, it would be meant to be something that sort of galvanizes, all or as many organizations within and across the health system as possible to be working in a way that's consistent with the principles and values that underlie health equity. And finally, recognizing again that we have a lot of work to do to build capacity within our system. With respect to health equity and working in an equitable, safe, inclusive way, we're hoping to create a sort of single entry portal for health equity capacity building. We have a very high demand for health equity capacity building training. The existing pieces that are there are useful and important, but not necessarily meeting the needs of, say, folks who are working on the front line, who aren't sitting in front of a computer like I am every day. Those folks have unique needs in terms of modality of delivering training like this, and perhaps even a different focus or way that information can be presented to be a bit more relevant for their own context. So we're hoping we started scoping this out. It's fairly early days, but we're hoping to get something in place that provides an efficient way for folks to get that training, no matter where they are in the system and what unit they belong to. So that's really where we are now. We're moving forward on all these pieces all at the same time with our system partners and with our team here. A lot of work to do, a little bit more planning coming up for the next fiscal year in terms of how we focus on this, but that's where we are currently. And so we're a little ways down the road, but we have certainly a long way to go. So thank you for sharing some of your time with me. I really appreciate that. And with that, I'll turn it over to Karen and Chantal to take it from here.
Thank you, Eric. Thank you, Dru. Thanks, Nandini, and all who organized this. We will be looking at the local level. And to start, I'm going to say Deganuolado, salut, greetings. Chantal and I are situated on the unceded lands of the Kanien'kehá:ka of the Haudenosaunee. It's an area otherwise would be called South Glengarry, Ontario. As descendants of a wide variety of colonial settlers, it is our responsibility to understand how colonization has been used to gain unfair advantages, to create systems of oppression, and how these systems have formed our privilege. We know racism and our whiteness are not biological categories. We know that white supremacy is pervasive in all institutions and throughout all society, and that we have a responsibility in its dismantling. We function as allies and advocates, respecting original treaties, UNDRIP, TRC, MWEG, as well as respecting those who were brought here involuntarily, especially by the slave trade, and others on this journey towards cultural safety, anti-oppression, and anti-racism. Niawa, thank you, and merci. And I'll pass it over to Chantal. The next slide, please, Nandini.
Thanks, Karen. So as Karen mentioned, we're providing the perspective today of applying an equity indicators framework to a local organization. And so we're here today on behalf of our organization, the Eastern Ontario Health Unit. And so we are a regional health authority, regional health unit in Ontario, and we oversee a region that is a mix of small urban and rural communities. We have diversity in terms of in the southern part of our region, it's primarily English-speaking folks and about 20% of Francophones. And then in the northern part of our region, it's mostly Francophones. And then mixed in through there, we've got lots of really great diversity. And then, of course, we are bordering with Akwesasne, Quebec, and New York State, which again provides us like a unique sort of setup for the work that we do. So next slide. So why now? Our Towards a Culturally Safe UHU is really a call to shifting the way that we do things. So public health has traditionally, and for a really long time, really focused on shifting individual behaviors to improve health. So really focusing on what can the individual do? Should they eat better? Should they move more? And we've really spent a lot of time focusing on that. However, there has been a lot of recognition about what surrounds us, shapes us, and it has shifted the work of public health to addressing more of the environments that surround us and how they shape the way that people exist in the world and the things that they're able to do and how that impacts their health. But moving even further into this is really looking at recognizing how these systems and structures really hold people where they are. And so, as Karen so eloquently always says, is holding problems in place. And so this strategy for us is really about shifting those systems, because we know that we need to, in order to see actual change in terms of well-being and seeing healthier populations, we really need to get to the root and shift those systems. Next slide, please. In terms of why now, there's so many reasons why the timing was right for us. But most importantly, it's that there are many supporting changes co-occurring at this time that really has allowed us to sort of catapult this work. Primarily, we're currently undergoing a review of our strategic plan. And so realigning what our organization wants to focus on over the next 3 to 5 years. We're also looking at realigning with accreditation standards and requirements coming out of the pandemic, having to reshift towards that. Something that was also mentioned in the earlier slides is by other speakers is the shift to also focusing on psychological health and safety in our workplace. So a lot of that focus also lands really well with a cultural safety perspective. And then finally, just in terms of our role in public health, we are mandated by the Ontario Public Health Standards, which are currently under revision and should be out later this year. But health equity is one of our pillars. It's one of the foundations of public health. And as an organization, we have a responsibility to modify and orient public health interventions to really decrease health inequities. And that includes engaging priority populations to understand their unique needs, histories, cultures, and capacities, and also designing strategies that improve the health of the entire population, while at the same time decreasing health inequities experienced by priority populations. So I'm going to hand it over to Karen, who's going to talk a little bit more about the framework that we're using. So thank you. Next slide.
So we've all seen many frameworks in our time. So the big question is, what's different? Why did we choose this one? And I'm going to go through that. So the Equity Indicators Framework was collaboratively created by an Indigenous-led group called the Anti-Racism Network. This group included Becky Sasaskamus-Kuffner, Rhonda Rosenberg, Shannon Fitzsimmons, Heather Draws, Christine Brophy, Erin Walling, Annie Baptiste, and Michael Hemlick, under the tutelage of anti-racism expert Dr. Verna St. Dennis. All creators are from Turtle Island, specifically the land colonially known as Canada, making this tool specific to Canadian circumstances and situations, but it is applicable elsewhere. This framework is identified as a transformative source to support organizations such as public health units, provincial governments, and organizations in critically assessing and measuring approaches toward cultural safety, anti-racism, anti-oppressive methodology. It applies this methodology to expose uneven power dynamics between the groups and the structures that sustain them. It is evergreen. It centers on action rather than awareness. And although I'm not a framework expert, this was the first equity framework that I had seen do this. There might be others now, but it was the first one that I had seen do this. It does provide specific examples of what each of the categories look like. The equity indicators framework creates opportunity for an adaptive transformative intervention in mainstream systems while allowing us to continue to meet our current needs. Because one of the things we're constantly struggling with is how do we get this done when we're not being given any time or resources to do it? The framework is as much about oh my goodness, I'm struggling with my words today. It is as much about learning and engagement experience for dominant identities as to begin to make collective impact. It is an intervention to mitigate the harm for the identities who have been historically marginalized in conventional systems. And I think that's an underlying piece too. When we look to our own community, these were the pieces that were coming up. Next slide, please. So we've been gifted to be able to share a piece of this framework with you. And I want to read the message from one of the authors, as it underlines the importance of why we can't just give out the framework. Our current organizational structures uphold values that harm marginalized identities, in particular Indigenous peoples in Canada. This leads to widening social outcomes and costly initiatives on unceded Indigenous lands and territories. Colonial systems are designed to reproduce themselves. Very important concept. If you are not gifted a decolonial lens through education or birthright, no matter how well-intended you are, a colonial worldview will yield colonial results. Not sharing the framework is not to gatekeep or create barriers to knowledge creation. The goal is to mitigate the harm we know is happening and offer real transformative action. And this was with love from Treaty 6 from Becky. At the same time, she's sharing a glimpse, and this is a process that we're undertaking. How this framework works is from left to right. You start in the category of maintaining colonial processes. You move over to tokenism, you move over to EDI, and the big jump here, or the big difference, is that we look at cultural safety, anti-racism, and anti-oppressive processes and structures as a separate and distinct column. And that is another little piece that in our current world, we're not seeing that. We're seeing EDI as an endpoint. So briefly, although there's two examples under each of these columns, briefly, I just want to explain that when we look at maintaining colonial processes, we're not looking for change, okay? We're looking to keep the focus on whiteness and to keep the focus on hierarchies. Again, it's all about power and control, right? When we dig a little bit deeper, it's that top-down control piece, and it's Becky so beautifully calls it, it's becoming a better caterpillar. It's not changing anything. If we move over to tokenism, which is the second column, we're getting into more that this does not represent the population. Okay, we're looking at more of the performative actions, but only giving a very limited amount of power. So decision making is not in the hands where it needs to be. It's more like, and we see a lot of this, especially with the festive season just having passed, it's that charitable response. And so basically the structure isn't changing at all here. It's just making things look pretty without making a difference. When we move over to the EDI column, here we're starting to see a shift in power, okay? But it's still, this column is trying to maintain whiteness within its power, just kind of shifting words and everything around to make it look so much better. But at the same time, there is a willingness to change, but not knowing how to go through the process, not knowing how to go for the next step. What it does create is a lot of space for discussion. It allows for greater building of relationships. It looks for space for lived experience. We're digging into different voices at this point. Right now in this column, as Becky would say, again, one of the creators, it's that you're trying to change to a butterfly, not just a better caterpillar. Now, where the big shift happens, and I before I go into that next process, I do want to say that knowing where you are and situating yourself, even if you're not where you think you are, is not a bad thing. It's actually knowing better so that you can do better in the future. But when we're not being honest, we're maintaining those processes and the systems and the structures in a place that keeps everybody else safe. And that is not good enough. That is really not good enough. We're not going to see any changes ever we're not going to see populations, we're not going to see people thrive, we're not going to see sentient beings thrive if we maintain this. When we move over, what I want to say too is that you're never going to jump from maintaining colonial processes all the way over to anti-oppression. Okay, it's a gradual change process, but at least we can see what it looks like. When we become a culturally safe or an anti-oppressive or an anti-racist organization, this is when we're seeing the butterfly come out. Okay, we're now, it's that we cannot initiate our way out of anti-oppression. Okay, we can't do that. This is a forever changing column at this point in time. And it really shifts from ownership to stewardship. It's no longer one person's problem, and we're all working on the same kind of path. The nicest thing about it is it is extremely genuine at this point. So I want to thank the creators because, like I said, we've been gifted a little bit extra knowledge and a little bit ability to share in more detail. And now perhaps we can see why it's so good. So I'm going to ask for the next slide, please. So what happened internally at the health unit is that our project charter was finalized and it was endorsed by our medical officer of health along with the Board of Health. We were able to complete the initial assessments and strategic planning, and which was very timely and has potential for huge impact. And we're working with human resources at this point in time. So under staff engagement and knowledge exchange, it came through the mandatory foundational of cultural safety courses that all staff are having to implement or attend, I should say, and Bridges Out of Poverty training. We also did an email blast to kind of get people aware a little bit more of what cultural safety was going to be about. And we also have an internal web portal so people can go to that location, or staff can go to that location at any time and look into it. The other part is that the team has grown significantly, and we are open to all staff asking us questions or at any time. So we have also formed a human resources sub-team. So they've completed their own assessment of the equity indicators framework, just with the pieces that were pertinent to the work that they do. And with that, there's been prioritization for 2025. We've adopted, and we're very excited about this, branding, which we're sharing with you today. And yeah, we're really proud of it. We'll get into that in a few more minutes. Our core team has been using the equity indicators framework to build a baseline and identify opportunities for action. It is iterative. It's an iterative process, meaning we are constantly being able to update and change and add resources and shift, and which is it's phenomenal. The whole project is committed to working with the Anti-Racism Network to become a culturally safe organization. So we're leaning on people. We also have a local strong engagement with an IDEA Community Coalition, the Prescott Russell collaboration, as well as many sibling organizations locally. Next slide, please.
Thank you, Karen. And so Karen, I think, summarized a lot of the things that we're currently working on. And like we said, we have a sub-team of human resources that are currently focusing on some of their priorities, which are really around our recruitment processes, and then our onboarding processes. So how can we make that more culturally safe? We're also going to be leaning in and inviting Becky and some of her team members, so the creators of the framework, to come back to our region along with partners so that more people can receive in-depth training on anti-racism, trauma-informed practice, and on the actual framework and how to apply it. Our small core team is also focused on developing a corporate policy and procedure on cultural safety. And so this will become sort of the underpinning that will help guide the organization, recognizing that this isn't something that belongs to a team. Moving towards being a culturally safe organization is really all of our responsibilities. And so we're really working hard at bringing more people, more team members on the journey, and everyone taking ownership of the part that belongs to them. On that piece, a lot of it is about internal engagement. So we have presented the strategy, like Karen mentioned. We have an internal portal where we are housing resources, information, meeting minutes, and it's really just about being transparent about the process that we're undertaking, and also allowing people to sort of learn and grow along with the process. The other piece that's really exciting is from a program and departmental perspective. As we've been talking more and more about applying a cultural safety lens and really using the equity indicators framework, it's generated a lot of really interesting conversations with other program teams who have priorities themselves within their programs that align with the work that we're trying to do. And so we are working together to sort of align some of these priorities and really showing where if you're working in a program that's more related to gender diversity, or if you're looking at, I'll give an example. We have our substance use health team that's really focused on substance use health stigma, and they have their own priorities. And so we're aligning it with the cultural safety strategy to make sure that people don't see these as separate actions. They're really actions that support one another, and it allows us to move in a really concerted effort towards changing the way that we're doing things, not just at a corporate level, but also within our programs, within the way that we work with our partners, and also in the way that we work together as colleagues. And so again, it's really about seizing those opportunities, and we're excited about what's going to come out of this. So next slide, please.
So I know we've gone over our time, so I'm going to just say really quickly that this is us. This is the Eastern Ontario Health Unit. This is our Thriving Meadow. Really quickly, I don't know if you noticed, but we had a wall up, and every step we take, we remove the bricks, the man-made bricks, in order to share the Thriving Meadow at this point in time. So I'm going to say thank you to all. Merci, Niawa. And Nandini, we'll go back to you.
Thanks so much, everyone. Thanks so much, Dru, Eric, Karen, and Chantal, for sharing all of your insights and experience. So that was just amazing to hear the range of work that is happening in very different organizational contexts. So I think in the interest of time, we're going to move forward to the participant Q&A. And because there's actually quite a few questions that we've received in the Q&A chat box at the bottom of the screen. So I'll invite Chantal, Eric, and Dru to show yourselves on the screen if you like, so you can take part in this Q&A with the participants. So one of the things, actually, there's a couple of questions for you, Eric, specifically around engagement and who was engaged to develop and co-develop the health equity framework at Nova Scotia. So from Melissa Klein, did you engage specifically with equity-seeking groups? So maybe we'll start with that question first.
Sure, thank you, and thanks for the question. Yeah, yes, absolutely. In fact, the vast majority of folks we spoke with were specifically either individually or as a community or a group representing underserved, underrepresented communities, including Mi'kmaq leadership here in Mi'kma'ki, other Indigenous serving organizations in urban areas, African Nova Scotians and other African descendant communities, 2S LGBTQ plus IA communities, faith-based communities, a whole range of other communities underneath this as well. And as we went to, and as we had more discussions, as folks can imagine, others who are not specifically listed or included in the legislation, and there is a list of specific communities named in the legislation. Other communities emerged from those discussions that we followed up with as well, to get a sense of again, not just the particular perspectives that they were sharing and bringing and wanting to share and did share with us, but also how that impacts, for example, intersectionality within and around some of the pieces that we had learned prior to as well. So, and I should say beyond that, and even in advance of the engagements we conducted, we were sure to do as comprehensive a review of information that had already been shared with us as a government and as a health system. So many communities had taken it upon themselves to share their experiences historically and currently with the health system. And so instead of going and starting an engagement process by saying, hey, can you tell us what your community's experience has been? We did our best to learn from what had already been shared so that we could start the conversation by saying, here's what we learned from this, here's what we know. Does that make sense? Is it accurate? Does it ring true? And then if it does, or even if it doesn't, please fill in, whatever else we need to know, and or ideally take it forward from there to kind of add more contextual pieces and any information that would be helpful to inform this work. So I'd say it wasn't a perfect engagement by any means. We didn't get as much representation from some communities as we would have liked. But given the fact that we had a legislated timeline of a year for official launch, we had to do the best we could with the time that we have. And I think we had a reasonably respectful start. But as you can imagine, those engagements haven't stopped. They continue, and they'll just become a little bit more focused and tangible as we go forward. So hopefully that gives you a bit more information about the process that we took on. Thanks for the question.
That's great. Thanks, Eric. Just in follow up to your comment that there'll be sort of ongoing engagements. Stacey Gomez has shared, having reviewed the Nova Scotia framework, we noticed there was a gap in terms of consulting with migrant workers, also known as temporary foreign workers. And just wanting to know if there are any plans to address this, to connect and engage with this particular community.
So I would say there's specific plans at this moment. The pieces that we're working on that I shared are, generally speaking, sitting at a system level, in that they would ideally, hopefully, improve safety, effectiveness, representation across all communities, underserved, underrepresented communities. So generally speaking, I would say we haven't necessarily gotten down to the individual community level to sort of follow up on some of those pieces. I think we have a lot of internal work to do with the information that's been shared with us, and would like to have a body of something to bring back for folks to engage with, to move us, to help us and continue to help us moving forward with that. But of course, that's in recognition of all the work that we have to do within the system to be able to act on what we've learned. But as I said, the door is always open for those conversations as we go. And certainly we'd be happy to follow up. So please get in touch with me outside of this. Thanks. That's great. Thanks, Eric. Appreciate you wanting to connect. Another question that also has come up, which I think is something that we all sort of face and try and address. So Stephanie has asked, what strategies do you find effective when engaging with key decision makers who do not value the social justice foundations of the work that you do? So I don't know if Dru or Karen or Chantal would like to jump in.
Sure, I can start. I just want to be clear, I'm a frontline worker, but I think I overstep my boundaries often in life, and I do speak with key decision makers. One of the things that one of the biggest pieces that I think, when you believe that this work is important and that that it's going to shift populations and thinking, then it's coming from our heart, it's coming from a good place, that gives us the strength to go on first. So I want to say that first. The second part is picking and choosing who those you're going to talk to. Like, I'm just too old and too done with people who I know aren't going to change their minds. So I put absolutely no energy there anymore. And then it was shared with me. It's called an allyship barometer. I can share it with Nandini later. And focus on the people whose minds you can shift. And that way, instead of being one or two people, you're going to be 10 or 12 people. And the person who's way at the other end, the naysayer, we don't have to worry about them. And so I would be looking at the other people and shifting the people around you to start with. So I hope that helps. Not easy, but I hope it helps. Thank you.
If I can add to Karen's piece, absolutely, we try not to spend any time on those who are not engaged, but those who might be kind of on a tipping point, and maybe they're just stuck in the weeds of their own priorities and their own projects. I think what we've been trying to do is sort of demystify what we're trying to do and bring it to a level of how does it make sense for with the work that they're doing. And I see some of the questions in the chat about like, how do you relate this to like the quality of life framework or another framework or other program priorities? And this is where we've been really intentional about really showing people, like visually, we've been making the connections between the equity indicators framework that we're using and the work that we're doing, and how it relates and ties to and actually supports the work that other people are doing, so that they don't feel like we're moving forward on something that isn't going to be supportive of their own priorities and their own work. Because I think you need to learn how to speak people's language and also bring them along the journey. So that's been really helpful as well.
That's great. Thanks, Chantal. So just looking, we actually have quite a few questions. So maybe I think we've got about 3 minutes left. So maybe we can just focus in on one question, which is actually around, did any of these initiatives include the development of an equity-based data governance framework? Or include the development of any sort of equity indicators? I don't know, Dru, if you would like to share anything around that, or we can move to someone else as well.
Yep. Unfortunately, we haven't got to the stage of indicators. But in terms of data governance framework, we are developing that across the organization. And so I guess that's where having the framework, our team develops it, we take that and apply an equity lens to that to hopefully improve it as it enacts. So a lot of internal application of our framework within the team.
And I think we have time for maybe one last question. Someone was asking about if any of the frameworks that you've been involved with developing or co-developing, and if any of them sort of take a staged theory of change or change management kind of a process to how your framework is organized and presented. So I see Chantal, Andrew, and Erica, you're all nodding your heads. So who would like to have the last word before we close the webinar for 1 o'clock?
Me.
Go ahead.
I think I haven't technically applied that, but I do have a psychology background, so maybe it's part of the influence. But I think actually it's not in terms of rollout of implementation, but I think our actual framework follows those stages a fair bit. So that first part about understanding differently is kind of that kind of contemplation stage, and then you get to a commitment before you can actually take action. And so it does kind of follow that process. Also in the third part, enabling change conditions, again, that's about trying to set up the right conditions to make a change before you get to the action taking part. So I think by default, it is in there. So in terms of rollout, if you can follow the framework, then hopefully you are following the stages of change.
Thanks so much, Dru. Thanks, Karen, Eric, Chantal, and Dru. Really appreciate all of your amazing contributions and all the work that you're doing. And thank you to all of our participants for engaging so actively in the chat box and in the Q&A. And I know everyone on the line also has tremendous experience and expertise, so we're so excited to connect with you today. And just wanting to invite you to complete the evaluation of the webinar. You'll receive the link, I think, as soon as you close the Zoom room. And we will be posting the slides and the recording to the NCCDH webinar after today's session. Yeah, please stay connected with the NCCDH. And if you have any questions or comments, or you'd like to connect directly with any one of us, please just send me a message. You can reach me through the NCCDH website, and I can connect you with the panelists if you'd like to connect directly. So thanks, everyone, and wishing you all a great rest of the day.